Dear students of batch 22, after having discussed with the lectures on endocrine disorders, we shall now proceed to the renal disorders. Okay. The learning outcome stays the same because a patient presenting with a medically compromising condition, the first thing that you have to do is uh, seek a physician's opinion, the patient's physician, because already the patient is under the care of the physician. So we cannot proceed with the treatments that can interfere with the treatment under which the patient is already on. So it is essential for us to obtain physician's opinion regarding the patient's fitness for your proposed plan of treatment. This is because the medications which the patient may be taking may interfere with your treatment plan. Maybe it starts with our routine antibiotics, analgesics, especially the NSAIDs, and the local anesthetics. So at every point of your the step of your treatment plan, you may have to customize the treatments according to the patient's need and the patient's clinical condition. So you have to apply the knowledge of the medical disorders already, and then you can take clinical decisions based on this. So regarding the renal disorders, see now we are seeing the manifestations and then the gross anatomy of how it is. The kidneys are, and the basic functional unit of the kidney, which is called as the nephron. It contains the glomerulus with the Bowman's capsule, and then you have the proximal convoluted tubule and descending loop of Henle, ascending loop of Henle, and distal convoluted tubule, into which the filtered blood goes, and then various substances which are of more importance like glucose are being reabsorbed, and then only those which is not needed by the human body is being excreted along with the urine. So the urine which is produced by the kidney, which is a filtrate actually produced by the kidney, descends through the ureter, collects in the bladder, and gets excreted. Okay, so when the kidney is not functioning well, the whole this whole process gets disrupted. So when it is happening for a long time, the patient will result in chronic renal disorders. Okay, the manifestations of chronic renal disorders being it is multivarious because it depends on the system which is involved. So it starts with your psychological manifestation of depression, psychosis, lethargy, apathy, and weakness, and then polydipsia with nausea with the GI manifestation, hypertension, renal colics, back pain, polyuria, constipation, peptic ulceration, especially those affecting the bone metabolism. Okay, you have bone pain, pathological fractures, and we will come to know about why all these things are happening because of renal disorders. We will come to know as we go through the discussion. Okay, so this is for your understanding. The functions of kidneys. What the kidneys do actually. What the kidneys do actually. They are important in maintaining the homeostasis by maintaining the body fluid volumes and its composition, especially maintaining the acid-base balance. Okay, I think you people are how many people know about Professor B.M. Hegde? He was the former vice chancellor of Manipal University. He says he once, and in his lecture I have heard that every human body is like a chemical soup. Almost 70% of our human body contains water, and then the electrolytes. So the kidneys play an important role in maintaining the balance between acids and acid base and the fluids by properly excreting what is not needed, and then taking back what is, reabsorbing what is required actually. Okay, to our point, the most important is that all the drugs that we sorry all the drugs that we give are metabolized through the kidneys. Our routine drug pharmacological armamentarium comprises of local anesthetics, analgesics, and antibiotics, isn't it? So, when all these things are excreted by the kidneys, it is imperative that the kidneys are of in normal health, so that the metabolites don't stay in the human body for a long time. If not, they will be exercising adverse effects. So the toxicity level can easily be surpassed, and then that will have deleterious effects. So we need these metabolites of the drug to be excreted once the pharmacological effect is over. So for that, we have to make sure that the kidneys are functioning normally. Apart from that, kidneys play an important role in vitamin D synthesis. And it has play an important role in erythropoietin synthesis, which is the your RBC's production. In that aspect, kidneys are seen as more like an endocrine gland. Okay, they convert that the active form of they produce the active form of vitamin D called vitamin D3. Okay, which gets converted into vitamin D. So while the renal problems are many, you have acute renal failures, you have nephrotic syndromes, you have patients with renal transplants, you have patients with lithiasis, that is renal stones are there. So why this chronic kidney disease is only being discussed? Because this is most common. You will, in your daily clinical practice, you tend to see more patients with chronic renal disease because most of them are ambulant. They are already they are undergoing dialysis, and then once they develop any kind of dental disorder, not only for extraction purpose, they can come to you for other dental treatments also. So you have to have a clear picture, or you have to have a clear understanding of this chronic renal disease and how this condition is affecting my treatment planning. So certain facts that you acquire during the discussion may be helpful in taking proper clinical decisions when you are treating the patients. So why there is chronic renal failure? The renal function rate is measured by glomerular filtration rate, which is around 120 ml per minute, 120 ml per minute per 1.73 meter square of the human body. And then when it drops because of multivarious reasons to as less as 90 ml per minute per 1.73 meter square, then you call it as a chronic renal disease. Remember, out of every 100 ml of blood in the human body, 25 ml is always undergoing the purification process in the kidney. Okay, so when this effective filtration is not achieved, then it will have its associated consequences. The causes of chronic renal disorders being hypertension, diabetes, chronic glomerulonephritis, okay, renal artery stenosis, and analgesic nephropathy. Look at this word, analgesic nephropathy. This is one of the major concern of self-medication, especially dental patients, especially dental patients, because dental patients think that the pain can subside very easily by taking analgesics. So first time they come to a dentist and then they get the consultation, we give them analgesics and antibiotics, and then they make a note of this analgesic. And when there is a risk of over-the-counter availability of this analgesics, the patient himself can go to the pharmacy, and then get these analgesics and then self-medicate himself for even minor pain, and then the patient can cause damage in the kidneys, which can lead to analgesic nephropathy. Okay. What are all the clinical features? We have seen already. It affects almost many systems. So nocturia, that is urgency to pass the urine at night, anorexia, azotemia. This is hyperuremia, collection of urine in the, urea in the rise of blood urea level. Then it can cause hypertension also. Hypertension can lead to chronic renal failure, and then this chronic renal failure again predisposes the patient to a hypertension. That is a vicious cycle. And then anemia because of erythropoietin deficiency, because renal function is affected. Renal osteodystrophy, I told you, because it helps in the synthesis of vitamin D. And then it works with parathyroid glands also in maintaining the calcium calcium level in the human body, in the blood. So when these calcium levels drops down, the calcium which is in the bone gets mobilized into the blood to maintain the normalcy. So when these bones are being repeatedly depleted with their calcium reserve, the bone gets weakened, and then it is susceptible to pathological fractures. So patients with renal disease, if you are giving a bit of force during extraction, because the tooth is firm, remember, there is a chance of fracture of the jaw. Unusual or undue force which is being given in a patient with renal disorder who is already having a renal osteodystrophy, we are subjecting the bone to fracture which is already vulnerable. So you have to be careful about it. It can lead to secondary hyperparathyroidism, which is, I told you, because it works with parathyroid gland in maintaining the calcium level of the blood. And then it has the chronic renal failure patients may have bleeding tendency, because this is because of the effect of this renal disorder on blood platelets. It causes thrombocytopenia. Because of this thrombocytopenia, the bleeding tendency is more. And then due to all this, the patient is again susceptible to superinfection or secondary infection. So what is the treatment for this renal disorders? Patients are put in either they undergo peritoneal dialysis or hemodialysis. Peritoneal dialysis is one in which the entire purification process takes place in the tummy, because the peritoneal membrane is seen as an osmotic membrane. So the membrane through which osmosis can occur, semi-permeable membrane, the best semi-permeable membrane. So when the solutes are being passed through the peritoneal cavity, diffusion easily occurs, and then those substances which are to be taken out and then excreted will be absorbed through the process of osmosis and diffusion, and then they get easily excreted. In a nutshell, we should say that what the function the kidney is doing, the fluid will be doing inside the peritoneal cavity. So the textbook says that it is more convenient for the patient, so the patient can take the dialysis bag with him during the travel, and then they can do the dialysis. The patient can undergo dialysis as per the recommendations. On the other hand, hemodialysis is also happening. We have in our clinic, we have seen so many patients who are undergoing hemodialysis, and then you see the picture in the middle. The patient is having a arterial venous shunt. So this is the shunt which has an indwelling catheter, and then into which the blood goes for an extracorporeal circulation in the hemodialyzer, and once it is purified, it comes back. Essentially, the hemodialyzer will contain solutes and solutions which of various concentrations depending upon the need of the patient. So all the impurities, that means the waste products or metabolites in the blood which has to be excreted, will easily diffuse through the membrane and then get collected out, whereas the blood goes inside the human body. For this, when the blood is going for extracorporeal circulation, when it goes out of the human body, the blood will start clotting. Coagulation can happen. anywhere in the tubing or in the tube or inside the dialysis machine. So the blood should stay in fluid form. So for that, the patient is already infused with an anticoagulant called heparin. So that is called as heparinization. So it will not allow the blood to clot. So when the patients are posted for this hemodialysis, they go to around for sessions that I think it is for some, yeah, it is for some 3 to 6 hours. The patient may undergo dialysis per week. So the extraction should be carried out on the day after dialysis. Okay, on the day after dialysis, because the heparin effect should wean off, and then the blood should be relatively in a without any impurities, or like the metabolic products should have been taken off. So the extraction is better performed on the day after dialysis. This is an important viva question or MCQ, or it's an important concept that as a practitioner you have to keep in mind. So you should not have any doubt. So when will you carry out extraction for a patient under renal dialysis? You should say that I will do on the day after dialysis. Why will you do that? I will do that because relatively the metabolites will be taken out, and then the heparinization effect is not there. Okay. Then comes with our drugs. There are many drugs we prescribe to the patient because of the relative susceptibility of the renal patients. We will be prescribing antibiotics definitely, for sure. So what antibiotic to prescribe, what antibiotic not to prescribe? So there is a plethora of big list of antibiotics in this table, of which you see the safest drug. You see the metronidazole. Metronidazole we normally use metronidazole, and then lignocaine that we use normally for our block. It is quite safe. So metronidazole we use normally in our antibiotic spectrum. I mean, on our antibiotic coverage. So you can use metronidazole. It's quite safe. The fairly safe drugs in which the dosage change to be done in severe renal failures, we have the amoxicillin. Amoxicillin we commonly prescribe. Okay, this is where our physician's opinion is of big value, because the physician will assess the severity. Though we will be able to delineate the underlying medical disorder of the patient, we cannot take any decisions on the patient's medical condition because we are dental surgeons. So always interact with the patient's physician, communicate with them, and then once they give the clearance or fitness, then we can proceed. Among the less safe drugs in which you have to reduce the dosage even in mild, we have a list of drugs. Look at the last point, this NSAIDs and aspirin. It is better to avoid NSAIDs and aspirin in the renal patient because they have the tendency of gastrointestinal bleeding. Patients with renal disorders are already susceptible to peptic ulcers. So this will increase the chance of gastrointestinal bleeding and then the adverse consequences. So we have to be very, very careful in prescribing the NSAIDs. They say dosage reduction is indicated even in mild renal failure. The drugs to be avoided. We normally have the tendency to substitute our amoxicillin with cephalosporins. So we have to actually be very careful in prescribing cephalosporins also. So the drugs which are to be best avoided in many patients with renal failure are these aminoglycosides, gentamicin, tetracycline, pethidine, and OPS. These drugs we do not normally prescribe during our routine practice. So you don't, I mean, our spectrum of drugs will be with metronidazole, amoxicillin, lignocaine, and we have the cephalosporins. Okay, Ciprofloxacin, in very, very rare cases, we will prescribe ofloxacin, NSAIDs, and aspirin. All these drugs, we have to know when to give, when to not give, when to alter the dosage. Okay, fine. So why there is a risk of infection? Because the inflammation is already masked. Yes, patients with other coexisting conditions may be taking steroids. So the nephrotic syndrome. So the inflammation is always masked. So there is a flare up of infection. Yes, the patient goes for dialysis. Apart from the heparinization and other things, the patient is always carrying a risk of viral hepatitis, which is hepatitis B. So we have to be very careful in these things. And then antimicrobial prophylaxis is indicated for extraction, scaling, periodontal procedures. All these invasive procedures, we need to cover the patient with antibiotics to prevent any superadded infection. Okay. Then, yes, patients with renal transplants are already under long-term immunosuppressive drugs. So prophylaxis is indicated for them as well. Regarding the anesthesia, local anesthesia and conscious sedation, to be very safe, lignocaine is quite safe. We have seen already the list. So we can safely administer lignocaine in this patient. So lignocaine is not a contraindication, but GA is definitely a contraindication. GA is contraindicated, but in case if you need IV sedation, you can use midazolam, because this midazolam drug already we have seen it comes under the safest group of drug which can be prescribed in a patient with chronic renal disorder. Okay, what about the oral manifestations? Mainly in the heart tissue, which is the bone. There is loss of lamina dura. There are osteolytic lesions. I told you, because the calcium is being repeatedly transported from the bone to the blood. So all those effects will be there. Lamina dura, osteolytic lesions, giant cell lesions because of this altered calcium level, and then socket sclerosis. Then patients should be screened for bone problems before implants. So we have to be very, very careful in placing the implants as well, because the reparative mechanism of the bone is under compromise. In addition to that, the patient may have dry mouth, halitosis and metallic taste, and there is a reduced salivary flow. There is increased preponderance of calculus. This is directly proportional, because salivary flow is reduced, your calculus deposition is more. And then the patient's oral mucosa is pale because of anemia, and then the oral ulcerations are common. The patients with renal disorders can undergo very easily the bruises. So it affects the oral mucosa as well. Okay. So comes the dental management. Dental management regarding renal patient. Keep these things in mind. Bleeding, treatment carried out on the day after dialysis. These things are very, very important. The risk of hepatitis B transmission, you have to be very, very careful. And then if at all there is a bleeding is there, how will you manage? You can use desmopressin, and you can use cryoprecipitate, and then if not, you can use then if the bleeding is not stopped, you can use the conjugated estrogen. This conjugated estrogen can arrest the bleeding for a long time, but this desmopressin and cryoprecipitate, they're handy, and then you can use it for controlling the bleeding. The infections are poorly controlled, so we have to effectively cover with antibiotics, and then we have to be very, very careful in prescribing the NSAIDs. So as an end note, as the renal function is basically regarding the acid-base balance, there are two features of this acid-base balance: alkalosis and acidosis. It can be because of metabolic, and it can be because of respiratory. The metabolic alkalosis and acidosis depends upon the levels of bicarbonate, and then the respiratory acidosis and alkalosis depends upon the level of carbon dioxide. Okay, so you have the normal arterial blood pH. You know that the blood when the pH is less, the fluid is acidic, and then when the pH is more, the fluid is. So metabolic acidosis can happen When the bicarbonate level is less, this can happen in conditions such as shock, infection, renal failure. Other conditions are diabetes, alcohol, salicylates, the patients with biguanides, and all these things. They're on condition on drug with Addison's disease and renal tubular acidosis and other things. The metabolic acidosis can happen because of vomiting, burns, potassium depletion. So which cannot, all this can increase the bicarbonate level in the uh, blood. On the other hand, respiratory acidosis is a manifestation of respiratory failure, which is because of the increased carbon dioxide level. The pH drops down. That is, it becomes acidic. And then when this carbon dioxide clearance is more, the carbon dioxide level is depleted, the pH becomes alkaline, and then this can happen during hyperventilation, stroke, meningitis, because of anxiety, pregnancy, and pulmonary emboli and other things, and then aspirin. All these things because of, you have to know the difference between this acid-base balance, acid-base disorders, because of both respiratory and the metabolic, of which this our renal disorders play an important role. Okay. So with this, we come to the end of the session on managing the patients with renal disorders. Concentrate on dialysis part, concentrate on prophylaxis antibiotics, concentrate on the bleeding tendency, and then you be sure and certain of what NSAID is to be given or not. These are all the main take-home points. That, and then of course, when will you carry out the extraction? These are all the main take-home points regarding the chronic renal disorders. And then I suggest you to read the chapter of in nephrology on Carson and Scully, which is a textbook by the title Medical Problems in Dentistry. They have described everything there. Okay. So if you have any queries, you can post in our e-portal. Thank you. Bye bye. Stay safe, and then happy quarantining. Okay. Bye.